Thanks, Angie. Welcome to all of you. I'm so happy to have you join me today as I go over in this little mini lecture an introduction to the HuMap, the Hormone and Urinary Metabolites Assessment Profile. So the HuMap, as you will hear me refer to it in shorthand throughout this lecture, provides a comprehensive overview of steroid hormones, their metabolites, and the efficacy of the enzymes that metabolize these hormones. This is a non-invasive test. It requires only 4 to 5 separate urine collections. Because the breakdown of hormones relies so heavily on processes within the liver, this test can also elucidate areas of interest as it pertains to the conjugation of each metabolite. Additionally, testing urinary hormone metabolites can contribute to further understanding of endogenous hormone secretion, supplemental hormone utilization, enzyme activity, oxidative stress, and then insight into how our bodies are metabolizing hormones. This test is appropriate for males and females. Keep in mind there are no reference ranges for prepubescence. So males under 12 and females who have not yet started menstruating are not good candidates for this test. Now, a few things to note here on the instructions, which are included inside every collection kit. The QR code that you see here will give access to a handout that's titled Best Practices for Specimen Collection. And this handout can help answer any questions that your patients have. Collection instructions are on page 5 here. Patients are instructed to collect their samples at dinner time, bedtime, waking, and 2 hours post-waking. There is a 5th tube for collecting any urine that's excreted in the middle of the night. This collection is optional, but for patients who do urinate in the middle of the night, it is very helpful to collect it because remember, any urine that is not collected is data that we're not testing. Please ask your patients to carefully read the preparation section, number 3 here, because there's a lot of important information here. But the thing is information about which day to collect for cycling women, for example, info about dosage intervals for various routes of administration of hormone therapy, and also information about foods or substances to avoid before testing. And because we're using liquid urine, it's possible to add other tests to the same sample. You guys can add on neurotransmitter or amino acid testing to any HuMap test. Additionally, I do want to note that it's not necessary to limit water consumption for this test. 24-hour collections have been considered the gold standard for urine testing, but they are cumbersome. A 4 to 5 point collection offers some advantages to a 24-hour collection. Generally, patients consider collection of 4 urine samples easier than collecting all of the urine in a 24-hour period. The research indicates up to about 40% of patients who are attempting to collect every void over 24 hours actually don't collect properly, and at least one void is flushed away. And if we don't have a precise volume of urine for that 24-hour period, then the information we get from testing is skewed. So this 4-point spot testing takes that danger away. 4-point collection also allows us to measure the diurnal cortisol rhythm, where a 24-hour collection can only provide a measure of the overall cortisol secretion over the course of the day. And then what we do is create a 5th pooled tube to test hormone levels. So we get an average that corresponds very well to 24-hour hormone values. So this is the handout I was referring to, the best practices for HuMap specimen collection. It's available on the website, but patients can also access it by snapping this QR code with their phone. So it pulls up on their phone when they're doing their collection. And so it contains some information that might help them collect properly so that the results that are released to providers reflect the best information possible. So let me highlight a few of the things that you'll find on this handout. There's information about when hormone supplementation should be discontinued if it's necessary to do so. There's also information about foods and substances that can affect cortisol secretion and so should likely be avoided. Because it's possible to add neurotransmitter testing to these urine samples, that there's information here for foods to avoid if you're doing that testing. And remember, this information is also all in the instructions booklet as well, but the best practices document goes into a little greater detail. This test is appropriate for males and females, both pre and post-menopausal. For cycling women, it's important to catch the luteal surge, and that can be tricky when cycles are irregular. So there are some guidelines here. And there are FAQs included in this document, and I've just snipped a small sample here for you to see. All of the analytes on the HuMap profile are tested via liquid chromatography tandem mass spectrometry. So that's the LC-MS-MS. This is an extremely sensitive and specific way to measure many substances. In the case of urinary steroid hormone testing, LC-MS is used to determine both free hormone levels and their metabolite amounts in urine. So to put it simply, both parts work together to determine the exact amount of each hormone component in a patient's sample. The LC separates the hormones in a liquid urine sample, which are then injected at various times for MS analysis. MS technology monitors the injected sample for specific hormones based on their molecular weights and expected injection times, also known as retention times. Tandem MS verifies each hormone identity based on fragmentation and determines its amount. So here's the bottom line if you don't speak lab speak, and I'm not fluent in it myself, but we know that the combination of LC and tandem MS allows for extremely sensitive and specific hormone measurements, even in samples containing similar substances that would interfere with other methods. So here is the first page of the HuMap profile. This is what we call our summary page. I know it might look a little busy, but this is because we wanted to provide you with the most relevant markers on page 1. So this summary page highlights all of the most clinically actionable information in this report. So we determined this based on which analytes are the most well-researched, as well as speaking to providers who frequently utilize this test and taking into account the information that they utilize most. We know that providers have very little time. Our aim was to give you as much information at a glance as possible in the first 2 pages of the report. So we'll get into the second page in a little while, but I wanted to walk you through this first page, or this summary page section by section. So important clinically relevant markers are color-coded to respond to an individual's imbalances, which provides an at-a-glance format on the summary page. So dark blue indicates a marker is below range. Red indicates a value is elevated, and light blue through green into yellow is the reference interval. Because it can be functionally important to pay attention when values are trending high or low, we've indicated areas that correspond to low range and upper range. The same 15 analytes will populate on each half moon. Some people call this a half moon, some people a rainbow. But the same 15 analytes will always populate here, but the placement will be patient dependent. So the 15 analytes you'll see populating here are estradiol, estrone, estriol, as well as the ratio between 4-hydroxyestrone and 2-hydroxyestrone, progesterone, alpha and beta pregnanediol, and allopregnanolone, the sum of DHEA and DHEAS, testosterone and 5-alpha DHT, cortisol over the course of the day, the sum of cortisone over the course of the day, and also metabolized cortisol. Metabolized cortisol encompasses the sum of alpha and beta THF and THE. So these are the cortisol and cortisone metabolites added together. And you'll also see 8-OH2-deoxyguanosine populate here. You can also see that there is a little letter next to each analyte, an O, an E, an A. Now these correspond to the neighborhood in which these markers belong. So this is a reminder of the section of the report that you can flip to get more information on these analytes. Now here you can see how the same 15 analytes are populating differently based on 3 different patients' individual imbalances. So we'll move over to the estrogen section. In the estrogen section, from the summary page, we highlight the 2-hydroxy, 4-hydroxy, and 16-hydroxy metabolites and show how they are being methylated. So we've got these bar graphs here that represent the relationship of the percentage of the 2, the 4, and the 16-hydroxy metabolites. The expected percentage for each is represented by the shaded area, and where the patient falls is represented by this black line. And over here, we have a little snippet from the steroid hormone cascade that illustrates phase 1 and phase 2 metabolism of both estrone and estradiol. So here we have 2-hydroxy estradiol and 2-hydroxy estradiol and 2-hydroxy estrone represented. So at a glance, you can see the 2-hydroxy estrone is green, so falling right in the middle of that reference interval. 2-hydroxy estradiol is yellow, meaning it's trending towards the top of the reference interval. Then we can see how the COMT enzyme is working to move these markers into phase 2, which looks at the methoxy metabolites. Then here we have a marker of methylation activity. So you can see here we're looking at the ratio between the 2-methoxy estrone to 2-hydroxy estrone. So essentially, this marker in relationship to this marker. Now, methylation activity here that's highlighted is only representing the estrone component of these pathways. And we did that because the preponderance of literature is looking at estrone, and so at a glance, we wanted you to be able to get that information. Now, keep in mind, colors mean something in this report, and so red doesn't necessarily mean bad, it just means elevated. So for a marker that's looking at methylation activity, we know that methylation activity is actually working quite well. There's a lot of it, and when we're thinking about moving markers from phase 1 into phase 2, having a lot of methylation activity is a positive finding. In the corticoids section, cortisol and cortisone are plotted together for quick information about their relationship to one another. And you can see here cortisol is represented by the solid line and cortisone, the dotted line. Now to the left here, we're looking at the activity of the 11-beta HSD enzyme. And you can see here, this dial will show us whether or not we're favoring cortisol or cortisone. So this takes into account the amount of cortisol and cortisone that's secreted in that 24-hour period and compares the activity of that enzyme to tell us which one the patient is favoring. Some of the info that urine testing provides that other mediums like saliva and serum can't is the movement of analytes from one to another, which allows us to extrapolate information about enzyme activities. There are 3 areas of enzyme activity that we highlight here in the key relationship section. So you can see here the first is 5-alpha reductase activity. Metabolites in the 5-alpha pathway, if we're thinking about the testosterone section, we're able to see if the patient is favoring 5-alpha or 5-beta, because 5-alpha tends to be more androgenic. Even when hormone levels appear normal, we can have more 5-alpha activity, and that can be helpful to know because of those androgenic functions. So here we can see the patient is trending more towards 5-beta, so that would be a positive finding. We can also monitor aromatase activity. Now, aromatase, of course, is that enzyme that's found in the periphery, typically in adipose tissue, and it moves androgens into estrogen. So we're able to look at the movement of testosterone into estradiol, as well as androstenedione into estrone. And then here at the bottom, this enzyme is looking at COMT or methylation activity by looking at the 4 pathway. And of course, the 4-hydroxy estrones can be considered to be the most potentially mutagenic the most potentially risky in terms of thinking about cancer risk. And so we want to see if the 4 pathway is moving from the hydroxy form into the methoxy form or the methylated form. So we can see if the patient is favoring that OH or that M, and you can see here, we're definitely favoring the methoxy. And that was also represented in that red methylation box that we saw in that estrogen section on the summary page. Now here is page 2 of the report. This is where we're able to see the entire steroid hormone cascade. Now this is also dynamic and color-coded because it's displaying your patient's actual results so that at a glance, you can see markers that are high and markers that are lower. And here we see 3 different patients, each with colors that correspond to their individual highs and lows. Then the report moves into what we've taken to calling the neighborhoods, the estrogens, the corticoids, the progesterones, and the androgens. So again, these are heat mapped to show the patient's own highs and lows. Data is also listed out line by line. So we have the pathways above, and then every single analyte is listed with the patient's results, where they fall in the reference range, and then the reference interval indicated by the numerals. Now this, I wanted to quickly show you, this is a snippet I'm bringing down from the estrogen summary page. Now this is not part of this neighborhood, but I wanted to bring it down just now, just to show you how we want the summary page to give you great information at a glance, clinically actionable information, and we think it does that. But it can be helpful to dive into the neighborhoods, and here's one example of why. So remember here we looked at methylation activity, and we can see that there's a lot of movement from the 2-hydroxyestrone into 2-methoxyestrone and the 4-hydroxyestrone into 4-methoxyestrone. But if we look at the estradiols, that movement is not quite as efficient. So here we can see, the 2-methoxy to 2-hydroxy ratio, that's great. But if we look at the estradiol ratios of those same numbers, we can see it's not quite as efficient. So this is an indication that even though we have really efficient methylation of estrone, it's possible this patient could actually still benefit from some methyl support. So don't forget to dive into these neighborhoods if there's something you want to keep an eye on in particular. The last pages of this report will give you commentary based on the patient's highs and lows. So anything that's within the reference interval, including upper range or lower range, so that light blue or yellow section, those will not receive a comment. But if something is frankly low or frankly high, commentary will appear at the end of the report. Now there's some profile options. What we've been looking at so far today is the full hormone and urinary metabolites assessment profile, the HuMap. But Doctors Data is also offering smaller profiles for providers who want to look only at specific neighborhoods or areas of the hormone cascade. So there's an estrogen metabolites profile, a sex hormones profile that tests everything but the corticoids. There's an androgens and progesterones profile and an adrenal corticoids profile. Now here you can see an example of what you would get if you were to order the adrenal corticoids profile. So when might you consider running a urinary metabolite profile on your patient? So if we think in a general way, we know that assessing endogenous hormone metabolism as well as risk associated with certain metabolites, including an understanding of phase 1 and phase 2 detox, is really what it's all about. Hormone metabolite ratios that we provide on this report can help you assess for risk of things like osteoporosis, as well as certain cancers like breast and prostate cancer. Comparing phase 1 and phase 2 estrogen metabolites reveals how well methylation profiles are functioning. And urinary hormone metabolite testing can also be useful in complicated cases, such as when BHRT has not led to improvement, say in estrogen dominant symptoms, or maybe in a patient, for example, who has signs of HPA axis dysfunction, but when you test salivary cortisol, those values look like they're normal. For estrogens in particular, generally we're looking at these as a marker for evaluating breast health and in our male patients, potentially prostate health, because it allows us to do an evaluation of potential DNA mutagenesis. We get an evaluation of the metabolism of endogenous or exogenous hormones. If people are using BHRT, we can see how that is affecting the metabolism, and it allows us to look at that methylation potential, essentially the activity of the COMT enzyme. We're able to test the 8-hydroxy-2-deoxyguanosine marker, which is not an estrogen metabolite, even though you find it in the estrogens neighborhood. That's where we report it. But we put it here because it actually pairs really nicely with estrogen metabolite information. In general, it's a marker for DNA damage that's due to oxidative stress. But we do find it can be helpful in identifying or confirming DNA damage from harmful metabolites, quinones, and DNA adducts that we could get if we have that preponderance of the 408 estrone and estradiol metabolites. When we think about the androgens, androgen metabolites can be really helpful if we're thinking about further evaluation of PCOS patients, because we're thinking about symptoms, but we're also thinking about the pathways and the enzymes and how all of these androgens are moving around. It can be really helpful to monitor the activity of the testosterone metabolite 5-alpha DHT, because this is the more active testosterone metabolite. And if we have male pattern hair loss or prostate enlargement or acne or hirsutism, 5-alpha DHT is often the culprit. So it can be really helpful to keep an eye on that. It can be helpful to evaluate enzyme activity. So in this neighborhood, we're thinking about 5-alpha reductase and aromatase. So aromatase, of course, is moving androgens into estrogens, and we are able to monitor that 5-alpha and 5-beta relationship in this section by looking at the ratio between androsterone and etiacalanolone. For the corticoid section, we've got glucocorticoids and some mineral corticoids reported here. So in this section, we're able to evaluate that enzyme activity that moves cortisol into cortisone, because we know that when there's too much movement into one side or the other, that correlates with obesity or metabolic syndrome or inflammation or thyroid function. So knowing if we're favoring cortisol or cortisone can give us some insight about different areas that we might need to focus on with our patient's health. And in the progesterone section, we are able to monitor progesterone itself, as well as the 5-alpha pregnanediol and 5-beta pregnanediol, which are sort of the surrogate markers for progesterone, because progesterone is such a fatty hormone. It's very difficult to find in the urine, although our sensitive testing does allow for that. We can do things like evaluate 17-beta hydroxylase activity. We can also look at 5-alpha reductase activity in this neighborhood. And again, further workup for patients like PCOS patients or young patients who seem to be not ovulating, because we can monitor progesterone and its metabolites in this neighborhood. Now, remember that the HuMap profile tests 4 to 5 liquid samples. Why is this an advantage? Well, the main advantage of testing in liquid urine is enhanced sensitivity, especially for those low concentration metabolites. If you're working with dried urine actually has to be reconstituted from the filter paper once that sample arrives at the lab. And this reconstitution can lead to a loss of polar steroid metabolites or creatinine in some patient samples. With liquid urine, samples can be shipped after being frozen for 4 to 6 hours. They can be processed faster and concentrated further to enhance the detection of low-level analytes. Steroid hormones and metabolites are also quite stable if the liquid urine, if preservative is used. So freezing stabilizes, and the addition of a preservative ensures that stabilization. So some of you may be accustomed to testing hormones in serum or saliva. So why are the results we get with urine different? Well, we have to think about the structure of steroid hormones. Remember, they're made from cholesterol. They're fat soluble. This means they're hydrophobic, meaning water-hating, and lipophilic, fat-loving. This renders them insoluble in water. Because steroid hormones are hydrophobic, they must either be bound to a carrier protein that allows them to travel in water, such as in serum, or conjugated into metabolites, which are water soluble, as we see in urine. So it's important to understand that while urine is water-based, saliva is more favorable for measuring fat-soluble hormones. When blood is filtered through the salivary glands, only the unbound free hormones pass through and into the saliva. And this concept really is foundational to understanding the appropriate medium to test certain hormones. If you feel like you need a refresher on steroid hormone physiology, and a lot of us do, we have a couple of resources for you. One is the Wellness Wednesday that was given in January called Hormone Testing Options Compared. There's a link here. It's about an hour long, and it talks about the benefits and disadvantages of testing in serum, saliva, and urine, and how that's really based on the steroid structure of these hormones. Additionally, I wrote a letter for the Townsend article earlier this year called The Clinical Utility of Salivary and Urinary Hormone Testing, and the link to that article is available here if you'd like to read more about it. When it comes to measuring bioavailable hormones versus urinary metabolites, these points are crucial. Urine does not provide a direct measure of bioavailable hormones like saliva testing can. Rather, it provides a measure of unconjugated sex hormones, things like estradiol, progesterone, testosterone, as well as these conjugated metabolites that have been excreted. Conjugated metabolites consist of hormones that the body has modified by adding a water-soluble sidearm. This is usually a glucuronide or a sulfate molecule, and this facilitates their elimination in urine or stool. The amount of hormone in urine essentially tells us what the body's getting rid of, not what is bioavailable for use. Doctors' data offers both salivary and urine testing, so whatever tool you need to use is available to you. And providers often ask us, what's the best medium for monitoring HRT or BHRT? And you can see here what our recommendations are for monitoring response to various hormone therapies, various routes of administration. And you can see here that our recommendation typically is saliva. And so let me talk to you a little bit in the following slides about why we think that urine is not necessarily the best method for monitoring response to bioavailable hormones in terms of establishing if the dosage is appropriate. If we think about oral, the answer is no. It's really hard to monitor oral supplementation here. And again, what I'm talking about here is not how it affects metabolites, but if the dosage of oral estrogen you're giving is appropriate. Generally, these levels will be overestimated. That's because oral delivery creates conjugated metabolites in two places. First, when they're metabolized or absorbed in the gut, and then second, when they move through the liver in that first pass. And this causes urine metabolite levels to be higher than actual tissue levels might be. Urine testing is not ideal for monitoring the dose of oral hormones. It can be used to monitor the metabolites that are made as a result of that therapy, though. So if your patient is currently using oral hormone therapy, make sure to have them discontinue the therapy for 72 hours prior to starting the test and during the day of collection if they're doing the HuMap profile. When we think about topical hormones, we generally don't recommend looking for response to dosage and looking for potency appropriateness in urine because levels tend to be underestimated. Urine testing generally does not reflect tissue uptake of topical hormones. Saliva is generally a better choice for monitoring these. Generally, topical hormones are just not seen in the urine unless very high potencies are used. Topical hormones, therefore, can continue to be utilized as prescribed on the day of collection. It's not recommended for monitoring vaginal hormone supplementation. Vaginal hormones could potentially cause direct contamination of urine samples. So because of that, vaginal hormones should be avoided for 72 hours prior to testing. And urine is not the best place to monitor for appropriate potency with sublinguals. And this is because sublinguals mix both topical and oral supplementation, and both of those were a no. So sublingually delivered hormones are not subject to the first pass, but the portion that's swallowed is oral. And so generally, if patients are using sublinguals, to avoid all of that confusion, please have them stop for 72 hours before collection. If your patients are using injectable hormones or pellets, you can kind of monitor hormone response to this. That's because these types of routes of administration pass through portal circulation, which is a little bit closer to endogenous secretion. We do see a steady increase in hormone levels with these methods, which potentially could be reflected in the urine. But remember, these are still excreted hormones, not tissue levels. If your patients are injecting or using pellets, please advise them to collect at the midpoint between doses. So the take-home question here, can I use the levels of unconjugated hormones to guide prescribing, unconjugated hormones in urine? My answer is no. So while these levels are reflected in urine testing, once hormone supplementation is initiated, a different testing method will be needed to guide dosing. Urine cannot accurately reflect therapeutic hormone dosing for most methods of administration. You can use urine for initial testing prior to initiating BHRT, but then you'll need to follow up using saliva. So in order to be able to see how hormone levels on supplementation compare to beforehand, it's a good idea to run salivary testing both before and after. While I believe there are better mediums for monitoring the appropriateness of potencies, urine is the place to see how hormone supplementation is influencing metabolites that can impact health. The 2, 4, and 16 hydroxyestrogens are a prime example of this. So if you're interested in knowing how supplementation is affecting the metabolism of estrogens, for instance, I would recommend testing after your patient has been using hormone supplementation for at least 3 months before you monitor to assess the influence that supplementation is having on metabolites. The clinical team at Doctor's Data has created a reference guide to help support you. This is available on our website. It contains information on how to read the report, FAQs, all possible comments are listed in the guide, as well as information on factors that can influence hormone metabolism. A benefit to testing with Doctor's Data is our extensive testing catalog. Based on information gleaned from our HuMap testing, you might find it beneficial to then order neurotransmitter and amino acid testing, saliva testing, GI360 stool testing, or further methylation testing. Neurotransmitters and amino acid testing is both done in urine, and so it can be added to any HuMap collection. Either the neurobasic or the comprehensive profile or amino acid testing. You've got examples of those reports here. And as we've discussed, if you're interested in looking at the bioavailable tissue levels of hormones, saliva is your best bet. And certainly if you want to test cortisol awakening response, saliva is where you have to do it. And for melatonin levels, we are able to test melatonin at 3 points over the course of the day, or you can add a nighttime sample to your cortisol collection. So those are available to you in saliva, and the stool testing that Doctor's Data offers that's really helpful as an adjunct test to urine hormone testing is the GI360 stool test, specifically because it highlights beta-glucuronidase. So beta-glucuronidase is an enzyme that breaks the tight bonds between glucuronic acid and estrogen in the colon. Glucuronidation via beta-glucuronidase provides a major route of detoxification and estrogen metabolism. Gut dysbiosis can produce an excess of beta-glucuronidase, which can lead to the deconjugation of estrogen, which reverts it back to its active form, which can then be reabsorbed into the bloodstream that contributes to estrogen burden and hormone imbalance. And methylation. Methylation is essential for the deactivation of reactive hydroxyl estrogen metabolites. DDI offers a methylation profile to assess methylation activity, as well as DNA testing to directly look for SNPs. So the DNA methylation profile is a buccal swab, and the methylation profile is a plasma test. Our liquid samples run with LC-MS allows for the testing of metabolites that may not have been available to providers before. So some analytes you'll see with the HuMap that you may not be accustomed to monitoring are progesterone, DHEA, allopregnanolone, androstenedione, and the estradiol pathways, the 2-hydroxy and 4-hydroxy estradiol, as well as 2-methoxy and 4-methoxy estradiol. So what makes DDI stand out? The summary page, the dynamic pathways for each section that give you a visual representation of an individual patient's highs and lows, multiple ways to look at enzyme activity, increased sensitivity and accuracy, especially at the low end of the range. Water restriction is not necessary. Up to 4 liters per day is acceptable. We have very competitive pricing. And you have the ability to add on neurotransmitter or amino acid testing to the HuMap sample. And also within the extensive DDI catalog, order additional testing for your patient that can help inform the information you got from HuMap. So again, that's the gut testing, the salivary testing, and the methylation testing in particular. And if you have any questions about the results, there's lots of people you can talk to. Doctors Data has clinical and scientific support available, and here is how to reach us. So thank you so much for your time. I'm happy to answer some questions.